Good afternoon, everyone, and thank you very much, Anne, for this kind invitation to give a presentation from an Italian perspective on COVID mother and maternity care. The new coronavirus was defined at the beginning of the current pandemic, the current king of China. Now, after 3 months, we better call the new coronavirus the evil chief of Europe or all over the world, because the situation changed completely. On December 31, China reports to WHO a cluster of pneumonia with unknown etiology. 1 week later, Chinese scientists identified the novel coronavirus, and 2 weeks later, there was the first United States identified case in Washington. 10 days later, WHO declared global alert, and 40 more days later, WHO declares a pandemic. So a rapidly developing situation. Just underline some aspects of the coronavirus, some characteristics. It is a recombinant virus. It's very easy to be transmitted from man to man, usually after a close contact with respiratory droplets. Could be also transferred via the respiratory secretion. And we must remember that coronavirus is stable on plastic and still up to 3 days. So we should make very clean the surface, the environmental surfaces. The viral shedding is continues many days after the symptoms resolves, up to 20 days. And the transmission could be during the pre-symptomatic transmission is possible. I mean, 3 days before symptom onset. It could happen also from asymptomatic carriers. A particular aspect is that there have been identified some super spreading events, for example, a scientific conference of municipality dinners or sporting events. And the incubation period is around up to 2 weeks. That is exactly the length of the quarantine indicated for COVID. Now, let me tell you about the last 3 months in Italy. The first cases in Italy was an imported cases of 2 Chinese tourists in Rome. You can see Italy here, Rome, the capital, and Lombardy, that is the most affected area with the COVID epidemic. 3 weeks later, was identified the first case in a little town of Lombardy, the first Italians, let's say the first Italian case, and the outbreak rapidly spread in Lombardy. And since March 11th, the government gave restrictive measures, more and more restrictive. And if we want to give some figures on the situation, Istituto Superiore di Sanità on April 20th make this summary. There are more than 181,000 cases, and around the 10%, unfortunately, among health workers, and only 1.7% of cases are below 18 years of age, and the number of deaths are more than 20 4,000. Luckily, I speak as a pediatrician, luckily only 2 dead below 18 years. So it was very clear, now it's very clear that it is not just a flu, as it was believed at the beginning of the epidemic. And currently, all of Italy is in lockdown until May the 3rd, and we are looking forward for the next phase, that is unlock Italy. We are talk about how this will be run. Coronavirus 19 really created a major overload for the health system. It was a tremendous struggle to cope with the huge number of really severely affected people that arriving at the hospital the same time to the emergency room across the Lombardy region. And you can see how tired was were the professional, and we must underline that all intensive care beds in the affected part of Lombardy were really filled up very rapidly with patients, and many patients had to be transferred to other centers to other region different from Lombardy. We have in Italy 5,000 intensive care unit beds, and these beds were not enough, and 5,000 for a population of 60 million inhabitants. And you can compare with Germany, that has 5 times more intensive care units, but has 80 million inhabitants. So 5,000, 28,000 with a different in millions people, not so great. On this slide, you can see the empty historic cities in Italy. You see Milan, that is in the middle of the most affected area with COVID. You can see Ponte Rialto in Venice. You can see Trinità dei Monti. I must say that it's absolutely a new situation. And the last time anything like this happened was in the 17th century during the European Great Plague. So in Lombardy, during the last 3 weeks, around 500, 1,000 dead people per day. And this huge number of dead people made a difficulty for the cremation. And you can see in the bottom left of this slide, the army transporting the coffins to crematoriums in other cities, because the Lombardy region couldn't just cope with such a large number of dead people. So we, neonatologists of the Italian Society, brought together an expert panel to create guidelines on how to manage maternity care at the hospital during COVID-19. We follow some guiding principle preparing the ad interim indication on COVID and breastfeeding. We had the goal to protect breastfeeding as far as possible and to maintain the relationship of the mother-infant diet. In fact, we had the memory of a previous experience during the flu outbreak in 2009, when there was no indication from the national societies, and there was some confusion about the right way of management of the mother-infant couple. Obviously, we try to applicate the precautionary principle in front of an infection disease, but we also balance our decision considering the pros and the cons of different options. What does it mean to advise for breastfeeding? What does it mean to use the breast milk substitute? And what does it mean to keep mother and baby together or to separate? Different options and different consequences. We, as far as possible, referred to the current evidence, and when the evidence was not enough, we decided to refer to good practice decided by the expert group. We had a limited knowledge on the COVID virus, but we used that limited knowledge. We know that the transplacental transmission was not established. There are some few reported cases in literature, but more research is needed to make a conclusion. At the moment, there are really very few. We know that the novel coronavirus is not detected in amniotic fluid, nor in cord blood, nor in mother's milk. So we can give the baby mother's milk. We can feed with mother's milk without any problem. We guess that antibodies against the novel coronavirus could be detected, not yet actually, but could be detected by research in the mother's milk. And this is a plausible presence because in the previous SARS 2009 epidemic, specific antibodies were detected. And in case of the neonates of the COVID positive mother, we face with usually healthy neonates with negative tests. And even if they became positive after some days, they usually keep completely asymptomatic. And one more comment about the difference between COVID and Ebola. Recent guidelines from WHO contraindicate breastfeeding in the Ebola virus positive mother, but it's a completely different disease with a very high lethality, and you can find the Ebola virus in breast milk. COVID virus is not so harmful for the newborns, and usually till now is not detectable in human milk. So the WHO last March 13th make an indication just to support breastfeeding for the COVID mothers. We issued our ad interim indication, the first version, last February 28th. Ad interim means that we can change in the future, considering the future knowledge, the incoming literature. The second version was issued March 22. And a third issue is expected by the end of April, but in general, we'll keep the same main messages regarding the compatibility of breastfeeding with the COVID mother. The indication have been published on maternal and child nutrition last April 3, and after publication, they were quite well accepted by the scientific community and with a great interest. We created 3 scenarios in our ad interim indication, depending on the health status of the mother. The scenario in A is that of a symptomatic or post-symptomatic COVID positive mother. We already know that the mother has a positive test, so we do this test also in the neonate. We keep together in an isolated, obviously, in a dedicated area of postpartum ward, but we sustain rooming regimen, and we encourage the mother for direct breastfeeding. Obviously, we should provide mothers with information and measures and tools to control the transmission of the infection from the mother to the neonates. In scenario B is that of a post-symptomatic mother under investigation. So he enters a hospital, admitted to hospital, but we don't know if the mother is positive. So we test the mother because obviously has some respiratory symptoms. If the test is positive, we test as well the baby. We keep them together in a rooming regimen in isolated and dedicated area of postpartum ward. And we, just in scenario A, support direct breastfeeding, obviously providing preventive respiratory measures. Scenario 3 is the third scenario, is that of a mother with symptoms. That means high fever, shivering, cough, a lot of respiratory secretion, that is too sick to care for the newborn. Could be positive, COVID positive, or just under investigation. We decide that together with the mother that there is no possibility to keep them together. They manage them separately in isolated area. The baby usually could stay in a neonatological unit, could be admitted also to NICU, but usually this admission is not depending on the COVID positive status of the mother. I mean that a baby, if get a COVID infection, is usually post-symptomatic. Usually they are fine. If the baby is in intensive care unit, usually it's admitted because of respiratory distress, and this could depend on the prematurity. We know that COVID positive during pregnancy and in the mothers could be a risk for preterm delivery. In this case, we consider to use mother's milk, but express without direct breastfeeding, no contact, and the milk, we don't need to pasteurize the milk. It's not recommended. No coronavirus is not considered a way, a via of transmission. We know that in some NICU, they do pasteurize human milk, but not because the mother is COVID-19 positive. Also in scenario 3, we should guarantee the preventive respiratory measure. Unfortunately, we didn't succeed to get an agreement about skin-to-skin contact with obstetrician, gynecologists, and midwives. So we decided as neonatologists not to put comment on this practice in our ad interim indication. But WHO suggested that skin-to-skin contact is safe. And I must say that coronavirus is not documented in vaginal secretion of COVID positive postmenopausal women, and also in the vaginal secretion of COVID positive women at childbirth, admitted in labor. The COVID epidemic has led to some complication, really, of the COVID crisis, or we can say that the COVID crisis has 3 different components. First component is that there was and there is some difficulties in the governance of the pandemic. This is a transnational difficulty, for example, in Europe, among different national governments, but also difficult in the national preparedness and the mitigation policies to deal with the epidemics. A second crisis, a second component of that crisis is economic. In Italy, for example, there is actual estimate of a decrease of the national gross product of around 15–20% for 2020. And the third component is related to the first two. It's the crisis of the shortage of resources to manage the refugees problem. No money enough for dealing with the refugee and the immigration problems due to the diversion of a lot of money to cope with the COVID pandemic. So we actually don't know which will be over the next weeks or months the complication of the consequences of this possible lack of care for the refugees. But I want to end this presentation with a message of optimism. We should try to do our best to turn this crisis, the current COVID crisis, into an opportunity. In Italy, for example, we realized that already have some national task task for the future, in the economical domain, in the education, in business and administration. But if you want to focus on the health domain, I can say that the national coordination in a health emergency should be improved, and also improve the integration between the Ministry of Health and the regional health authorities. Sometimes they gave different indication and contradictory indication. We should reinforce the public component of the national health system. You know that in Italy we have a national public health system, quite good, but we understand that we should ameliorate, for example, the community health care, just in the control of the epidemic, and to reinforce the hospital, the public hospital. We should increase the number, as previously I've said, of the intensive care unit beds, and we should really develop the telemedicine that we already use, but during this epidemic, actually, we use a lot to talk to patients, to families, to have a visual assessment of children and of newborns. So we can say that if we really want and have the strength to do that, it's time for a chance. Thank you.
Thanks for that great presentation, Ricardo. That was great. We have one question for you. You were talking about the guidelines, which are really interesting. Can you tell us a little bit the extent to which you feel those were actually implemented, and if there were any problems with implementation?
Yes, we decided to make a survey that is ongoing, but obviously the result of the survey will be available in next months. But from informal contact with different hospitals, we know that in most hospitals, the guidelines are implemented. And obviously there is an limitation that the guidelines were made only by the neonatologist part. And ideally, we should have prepared a perinatal, let's say, ad interim guidelines, finding an agreement between gynecologists, midwife, and neonatologists. This was not possible, but at least neonatologists and pediatrician actually has the same attitude and information from the society, and they came, let's say that we fix at least one variable. You understand what I mean?
Yes.
Otherwise, the situation is prone to be very confused.
Great. Can I ask you, I know it was very bad in the north, the epidemic, and in the south of Italy, it has not been so, there has not been such intensity of disease, but I think the hospitals in the south, perhaps like some of the hospitals we're working with in Mississippi, they've got prepared and they're all ready for it, and it maybe hasn't come yet. Can you speak a little bit to that situation?
Yes. In the north, the consequences of the pandemic was awful, because it happened without a specific preparation. It really, there was an explosion, you understand? In the south, but also in my region, in my city, that is eastern to Lombardy, the situation is much lighter. I mean, few COVID mothers coming to hospital, But also in Lombardy, the problem, the major problem was not with pregnant women and with newborn babies. The problem was that all the hospital was very rapidly reorganized, allocating room, allocated resources, allocated personnel. They opened wards, new COVID wards, and nurses and doctors were just transferred from one department to another. So the problem actually was not in the perinatal area, but and moreover, I can say, for example, in the pediatric area, that is not really newborn. The neonatal period is up to 1 month, so around 1 month. But what happened in Italy is that families were isolated at home, and obviously in the south, but also in my city, that is in the northeastern part of Italy, but mostly in the south, when everybody realized what was happening in Lombardy, they keep isolated at home, and pregnant women protect themselves. So very few COVID mothers gave birth in the last days in the south, particularly in the south. But in my city, neither one, no one, you understand? And we are in the north, because actually mothers protected themselves.
So how about the healthcare workers themselves that are sort of sitting there waiting to see if something's going to happen? Do you have any sort of messages for them? Because I think that's what a lot of places are like. In Mississippi, they're kind of, I remember we have it very badly now in Massachusetts, and we have many cases, but almost the worst part, although it was, you know, it's sitting there knowing it was going to come, but not actually having it yet. What do you think, like, the workers go through, the healthcare workers go through when they're waiting for that?
I should say that I don't want to make to deny the problem. It's a huge problem, but I can say that we have the advantage. We in the area where there is no a strong epidemic, we have the advantage to prepare ourselves and to anticipate and to use the protective measures. In Lombardy, no one knew what was happening during many days, and there was a great diffusion of the infection. And in Italy, around 110 doctors are dead, okay, and most they are GP, general practitioners, because they visited a lot of people. They thought that it was just a flu, but also at the very beginning, some scientific authority confirmed that it was just like a flu. So they were not ready to protect themselves. But now you have the masks, you have the protection, you have the protocols, you have the flow, the pathway for the patient from the entrance to the hospital until the COVID department. So I think that we can take advantage, unfortunately, of the sad experience of Lombardy and possibly in United States, the sad experience of New York City.
Yeah. Great. Well, thank you. And so now we're going to go back to the live part of this presentation and see if anyone of our audience has any questions for you. Thank you, Ricardo.
Thank you.
Hi everyone. So I think, hi Ricardo, thank you for that. That was great. We have a couple of questions in the chat, and then if anyone would like to ask Ricardo a question, please feel free to unmute your microphone and ask live. I will just read one of the questions that we have in the chat here. This is from a person called Frances Joan, who I'm not sure, she's in Canada, from Vancouver in Canada. She wanted to ask Ricardo if hospitals were not allowing women who had babies in the intensive care unit to bring the milk into the intensive care unit. That's what's happening apparently if mothers have a baby in the NICU, they're not being allowed to bring milk into the NICU that has been expressed at home. Can you speak to that?
This is not clearly fixed, decided, stated by the interim indication. We mostly address to the healthy baby that could be sons of COVID mothers, but not admitted to intensive care. So at the moment in Italy, behaviors are different. I mean, the protocols are different. Some use just the breast milk, express breast milk in the intensive care unit, raw breast milk. Other centers do pasteurize.
But are they actually saying women cannot bring their milk from home?
No, they can.
Okay. So at the moment in Italy, that is completely normal, that if you've got a baby in the NICU, the milk can be brought in. Okay, great.
Yes.
I have a question here from Jamie Ortiz. She said, we have asymptomatic COVID positive women who are choosing to be separated from their newborns. What can we tell mothers to help them decide if they want to separate or not? Let me just, as these are scrolling, hang on a second, I can't see the rest of the question. Can you see that? We've got lots of questions coming in now. So they want to know what we can talk, what kind of advice or counselling can healthcare professionals give to mothers about whether or not they should separate from their babies?
Well, you know that we have the indication. Obviously, the final decision is not only at the protocol, is also depending on the mother desire and the hospital logistic. But obviously, we have health workers can make a great influence, at least to relax, not to make the mothers worried about it. Because if the mother has the belief that the human milk is not safe, and we are not sure as a health professional, we don't support the option to stay together, to breastfeed. The mother at the end is not convinced, does not follow our indication. So is this, we must say that our attitude is very important, because different health professional and also different scientific societies with the same body of evidence induce to make different options and prepare different recommendation guidelines, just the same body of evidence.
Can you speak to that a little bit? It's very different in America, what the American Academy of Pediatrics has come out with compared to you. Why is that?
I mean that obviously the absolute reduction, not absolute, but almost absolute reduction of the risk of infection from a COVID positive mother to the baby is separation, obviously. This is immediately what an infectivologist could say: separate mother and baby. Okay, but this is the point of view of the infectivology, a very respectable health professional, but just his or her point of view. We should consider also that if we decide to separate mother and baby, we interfere with the relationship, we interfere with the beginning of breastfeeding. So how we value breastfeeding, how we value the relation between mother and baby in the first days of life. This is the great question that we must put. The answer is not easy, but inside a society is important to have a consensus on the infective point of view, or let's say the infectivologist aspects, but also in general of the health, the future health of the mother and the baby. And
Okay.
if we are saying to promote breastfeeding, we are saying to promote their health. So the final decision is a balance, should balance all these components. And it's not easy, obviously, but if you value breastfeeding, you can decide. Obviously, the baby has a little risk to be infected, the baby.
Okay.
It's obvious because we have some experience that after some days, the baby got infected, okay? But usually it is an asymptomatic infection or post-symptomatic infection. The alternative is to keep mother and baby separated during more than 2 weeks.
I have
And
lots and lots of
usually the baby is healthy, and you have a mother that is continually requiring information about the health status of the baby, and the baby is normal or almost normal, and you should keep two different, let's say, regimen of management: the isolated baby or babies and the isolated mothers. But in terms of general health, they are good. So you should you should think about them.
So, Ricardo, we have lots of comments here. Let me just read some questions and comments. So, Nikos from Greece, from Crete, says, in Greece, we have the tradition of keeping the babies at home for at least 40 days. Some religious influence together with tradition. So if the mother is asymptomatic or with only light symptoms and the baby's in good health, why not include in the scenario A and B early dismissal from hospital after birth? Mother and baby will be in quarantine at home. In a way, we've been doing this even before the pandemic.
Yes, I agree with Nikos. I mean that when we in Italy discharge babies from the maternity hospital, we keep contact with them, and they are isolated at home during at least 14 up to 1 month. Currently, due to the COVID epidemic, they are tested after 2 weeks and after 30 days, or until they are both negative, mother and baby. So actually they are isolated. And even if we recommended, or better, we suggested one week stay after childbirth for the baby, just to check the baby, we have experience in Italian hospital last week's early discharge or appropriate discharge after 2 weeks, after 2 days, 48 hours of life. If the mother is in good condition, the baby is good condition, you plan control at home by the community staff or by the neonatology staff. And telemedicine is important to keep contact with them.
I have a question here from Randy who says, for the scenarios you described, A and B, are you keeping the mother and the baby 6 feet apart and using screen as well as a mask per the CDC guidelines in the United States?
Yes, it depends on the local resources, but usually the mother has mask. If the baby if there is room enough, okay, room large enough to keep the baby 2 meters far from the mother, okay. If not, the baby keep the mask on.
Okay. And then Veronica Wiseman, sorry. Veronica asks,
we have sometimes also separate and a system of separation of
the baby's crib
material
from the mother's
separation. Okay.
Veronica says, what exactly is, how do you define poorly symptomatic mother? And it says, I assume you test all the infants in all 3 of the scenarios. And if so, do you do it right after birth or within the first 24 hours?
There is no indication to have the test at a precise time after birth, but usually in the first 20 hours. And how do you define post-symptomatic? Okay, it's all the situation when the situation when the mother is in condition, in fair condition, let's say, not good condition, but fair condition, and is willing and able to take care of the baby. And she's not really sick, upset, and sometimes she wants to, but she's not really able to take care of the baby. Because we also have the situation that we have not enough nurses, for example, to take care of different couples with a mother not able to take care of the baby. So it's better that case to separate mother and the baby, but particularly if the mother is really sick.
So Dr. Feldman-Winter asks, are there specific recommendations for washing the breasts or washing the baby? What is the thought about the virus on the skin and the risk of transmission from skin to skin?
Well, if we consider skin to skin in the delivery room, WHO support this practice also for the COVID mother. We in Italy have no information, but usually we don't do at the moment skin to skin, and mothers just feed direct to the breast, and the washing before the feed is not stated in the indication in protocols. But you should consider that there is no orophycal transmission, gastrointestinal transmission of the infection. So obviously we can guess that some coronavirus could be in the skin of the mother. Yes, it is part of the risk.
One of our questions here is, Doctor, have you had any infected newborns that have died because of COVID-19?
No, till now, no.
Okay.
We have we had neonates coming back from home with respiratory symptoms, and they were COVID positive, and one was intubated and assisted, but actually he was preterm babies, 35 weeks preterm babies, and healthy at birth, but this condition certainly influenced the severity of the infection in the first month of life, or in the first months of life, as it happened, for example, for respiratory virus, syncytial respiratory virus, or other respiratory viruses.
Okay, thank you. We've got a lady from Canada who asked about the skin washing, but I think we've dealt with that one. But Veronica from Cyprus also has a question. She wants to know, she said, in Cyprus we're following a protocol of the Greek Gynecological Association, and fathers are not allowed to be with mothers at the delivery of their babies. What is your view on this? And this is definitely something that's happening in the United States as well. A large number of pregnant women in Cyprus are very upset and anxious that they will have to deliver without their partners. And I have to say that we've heard a great deal in the US about people wanting to do home births because they feel like they're going to go into the hospital and they won't have anyone to support them in labor. So could you speak to that a little bit?
Yes, the lack of support during labor is really a problem. I mean, for the practical and psychological consequences of not having a friend or strict relatives assisting you. And it is also not safe, because the health professional or the midwife cannot have an absolute control always during the labor. So not to rely, but to have a support from a relative or an accompanying person increase the safe of labor. In Italy, we have different situations. Usually, gynecologists do not allow an accompanying person, but the last phase of labor, I mean the last hours, but not the entire hours. I think that this is under discussion. Is not a routine. Different hospitals make different protocols about it. I personally believe that the mother should have a loved person beside her during labor, but it's only my personal view.
I will say, I think my hospital at Boston, where we have a lot of COVID, they are asking people, they're allowing a person to come in, but they're asking that person do not leave. So they come in labor and they basically stay for the whole hospital stay. They're not going in and out. So I think that's one way some places.
Yes, this is another option already in practice in some hospitals. Yes, it's different. Yes.
Okay, and then we have someone on here from the World Health Organization who's just commenting that the expert committee will be meeting tomorrow to consider skin to skin. And Lauren Hanley, who is from Boston, is asking whether the WHO is reconsidering the recommendation. And Judy is saying that she thinks it's more some of the details on the basic rather than an actual reconsideration. So I think that is a sort of good note to end on too, that you know, all of these things are constantly changing. There's evidence coming in on all sides all the time. I just really want to thank you, Ricardo, for being brave enough to stand up for mothers and babies in this crisis at a very early stage, and also you know, in the awareness that we all have, that the recommendations are changing all the time and that we have to keep the evidence in mind, but these are the best practices that we have at the moment. And I think most of the people on this call will know that you know, this is something we all support. We're all in favor of the breastfeeding relationship and the mother-baby relationship, and a lot of people are looking for guidance in that area, and a lot of people are not brave enough to put themselves on the line. So thank you, and thank you everybody. Many people are writing thank you in the chat. Thank you for your time, and thank you so many people for coming on. And I just want to also thank Maytal, who works for me, who has edited and put this presentation together, and done a great work in terms of supporting the presentation from the technical aspect. So thank you everybody.
Thank you,
Ricardo.
Everybody.
Okay, it's been great to chat with you. This will be online, and we will put the information on our Facebook page and social media so that we know how to, for you to connect to this if you want to recommend it to other people. We've recorded it. Thank you very much again, and good luck in Italy, and good luck to all of you in all the different places who've joined us, who are coping with this epidemic all over the world. Thank you very much indeed. Okay, bye-bye. Bye-bye.